because cannabis is such a politicized topic, and the harms often get intermingled with the political desire to either prohibit or liberalize cannabis use. So this puts us as researchers in a bit of a precarious position where we're trying to pull at both ends, where we're saying to the prohibitionists, listen, it's not as bad as you're making out to be, and these scare tactics are not really helping anyone. And equally, we're telling the cannabis activists it's not completely harmless and a panacea for all human ailments.
You have found the Thinking Mind podcast. I'm very excited to have Dr. Amir Englund with us here today. Dr. Englund is a researcher at King's College London, but I will let him introduce himself a little bit more in a bit more detail. I hope we'll have a really interesting conversation for you guys today about all things to do with cannabis and CBD and many more things. So, Dr. Englund, welcome to the podcast.
Thanks so much. Thanks for having me.
Yeah, I was wondering if you could tell us a bit about yourself, what your work looks like at the moment.
So I'm a cannabinoid psychopharmacologist. I've been at King's for about 10 years now, where I started doing my PhD. And I've been involved with several experimental cannabis studies. So most of these have involved administering the active components of cannabis to healthy volunteers mainly, but I've also been involved with a few clinical trials where we've explored the potential of CBD as an antipsychotic medication. And more recently now, thanks to COVID, we've moved a bit more online, kind of working with already existing data and trying to set up some virtual experiments.
So I guess that kind of brings me on to my next question, which is what question would you say that you're trying to answer with your work at the moment, or what problem are you trying to solve?
Well, so I guess that kind of brings to why I started with cannabis research to begin with. You know, I grew up in Sweden, quite repressive country when it comes to drugs and drug policy. You'd think that it's one of the more liberal countries, but in fact it's not. So what I would call misinformation is what we received in school. So when I came to the UK and studied psychology, and then later on my PhD, I kind of slowly figured out that not everything that we learned about cannabis was true. And that dissonance created a bit of a desire for me to understand more about cannabis. So I read a bit about some potential medical benefits of cannabis, and that completely clashed with my pre-existing notions about cannabis, which I thought, you try it once or twice and you become a heroin addict or you go psychotic. So that wasn't really chiming well with what the scientific evidence was. So I wanted to understand more about the harms. So started studying, the link between cannabis and psychosis, and then that brought me on to just general harms of cannabis. And as part of my PhD, I guess my main focus was to understand the harms, but also how we could potentially mitigate those harms. So basically, and me and my colleagues in 2017 wrote an article where we argued, can we make cannabis safer? And that, has basically informed my previous and my current research focus, really.
I think this is such an important point that you raise, because it's a similar feeling that I've had myself, that the drugs education that we get at school just isn't that conducive for giving people the right information to make informed decisions, and potentially creates a risk where people get such a skewed view at school that, like you, if they go to university and find out something else, their behaviour might just be affected. They might just think that nothing that they've been told is true, and that there isn't any problems with drugs at all. And that's potentially where you start to see problems, where people haven't had the right information to make decisions. I mean, we talk a lot about the dangers of cannabis, but we probably need to touch on it again a bit today. What have you found to be the more balanced view of the dangers?
So the balanced view, I would say, is that it's neither a drug that would instantly make you a heroin addict or make you go psychotic from the first puff. And equally, it's not completely harmless and a panacea for all human ailments. The truth is somewhere in between, which, because cannabis is such a politicized topic, and the harms often get intermingled with the political desire to either prohibit or liberalize cannabis use. So this puts us as researchers in a bit of a precarious position where we're trying to pull at both ends, where we're saying to the prohibitionists, listen, it's not as bad as you're making out to be, and these scare tactics are not really helping anyone. And equally, we're telling the cannabis activists who think that you can use it from every ailment known to man, basically, that it's a wonder plant. So I would say that, just mentioning a few of the harms, the most common ones, I think, cannabis addiction, or what we refer to more specifically as cannabis use disorder, generally just means that you've lost control of your cannabis use. It's taken over a significant part of your life. It's become disruptive. It's affecting you psychologically, your well-being, your physical well-being. It's interfering with your social and work and study life, basically. So there's a whole host of, constellations of how cannabis can be problematic to an individual. So there's no one set way in which it is problematic. Generally, it's relating to, increased time spent using cannabis, increased time spent, getting a hold of cannabis, and giving up duties because you're doing those form of things. And also more physical symptoms such as tolerance. So the more you use, the more you need to achieve the same level of intoxication. And also, when you stop using or you reduce your use, you experience withdrawal symptoms. So I think in terms of the related problems you get from cannabis use disorder or addiction is probably the most common one. Then probably the most publicized one, the potentially most scary one, is the link to mental illness such as psychosis. Now, there's a big debate, and it's still with us, which is it causally related or not? And this obviously relates to, the type of research that showed a link between cannabis use and psychotic illness. And there's been lots and lots and lots of studies. Myself and other colleagues have written reviews, and other researchers have also written big reviews. There is somewhat of a consensus, I would say, that the link between cannabis use and psychotic illness is strong. So it's something that we can't really ignore, and we can't just say that it's spurious. Many studies across the world, different populations, have consistently found an association. Obviously, we can't know if the cannabis use is causing the psychosis or the psychosis is causing the cannabis use. Researchers have tried in different ways to kind of unpick what's what. And to this day, we know that, it can be one way or the other or both. So for some people, they get psychosis, and, potentially that mental state will lead them to enjoy cannabis more because of the unpleasantness of their mental states. And equally, some people who are vulnerable, who use cannabis a lot, can develop it from the use of cannabis. So I think a good way of looking at it is kind of like something like risk of cancer or risk of heart disease, is that it's a component cause. So it's not necessarily sufficient on its own to cause psychosis. So you need other risk factors alongside of it, but it contributes. So let's say that you're a heavy smoker, you're a heavy drinker, you don't exercise a lot, you have poor diet, you have a lot of stress in your life. Each one of those will contribute to an increased risk of heart conditions. Now, similarly, we know that for psychosis, there are things like family risk. So if you've got parents or siblings who have a psychotic illness, your risk goes up. If you live in an urban environment, your risk goes up. If you experience traumatic experiences throughout your life, your risk goes up. So there's a lot of different risk factors for psychosis, but cannabis is one of these. And I guess that if you have a vulnerability and then add cannabis use, frequent, prolonged cannabis use to that, that might push you over the edge and trigger an onset. But so I think a general good stance to take is that, take the cautious approach to cannabis and psychosis, saying that we'll never probably know if it's actually causal or not, but let's assume that it is and work on that basis to again, minimize harms of cannabis. So, who should really avoid using cannabis, and what kind of cannabis use is really the type of cannabis use to avoid to reduce the risk of psychosis.
And what have you found so far in your work about what that might be? What might be the factors that, like you say, reduce the harms potentially or reduce the risks?
Yeah, so some of these is the age of onset. So the earlier you start, the greater the risk of developing psychotic illness, it seems. Another one is the frequency and quantity. So how often you use it. More frequent users tend to have a greater risk of developing psychosis. And also those with family risk of psychosis have a higher risk. And also if you've had a drug-induced psychotic episode. So this is something that when you've overconsumed cannabis, you might, for a short period of time, it could be an evening, it could be a day, it could be a week, have a psychotic episode. Those people who have a drug-induced psychotic episode have a much higher likelihood of later on in life develop a chronic illness. So all of these risk factors should be used when considering, who's at greater risk or not. Then a few studies have found that potentially the addition of cannabidiol in cannabis might be a protective factor. And this is kind of the basis of, the paper we wrote to argue, can we make cannabis safer? Studies have found that stronger cannabis is linked to a greater risk of psychotic illness. But some of these studies also seem to suggest that the addition of cannabidiol, which is the second most common cannabis compound in the cannabis plant, THC being the main active component and the intoxicating compound of cannabis, well, the main intoxicating one. So a few studies seem to suggest that CBD could protect users. So one of my first studies that I was involved with at King's, we gave intravenous injections of THC to 48 healthy volunteers. Now, half of them were randomized to receive a capsule of CBD, quite a high dose of 600 milligrams, or placebo. So that was double-blind, randomized. We didn't know who got what, neither did the participants, but everyone got THC. Now, in this study, we found that CBD actually was able to block the paranoid effects of THC. So there was no significant increase among the participants who got CBD in paranoia. And we also saw some protective effects on memory performance. So participants learned a list of 12 words and then we asked 20 minutes later to recall as many words as they could. And there was about an 11-point drop in the THC group, which constitutes about one word less. But the group that had got CBD as well, they didn't drop in performance. So some slight indications. And also, when we look at psychotic symptoms more generally, 42% of those who got THC had what we call a significant increase. There's a specific scale that's called the positive and negative syndrome scale. And if you score 3 or more, you have what we call a significant increase, like a clinically significant increase. So that happened to 42, but that only happened to 12% of participants in the CBD group. So it's about 4.5 times less likely to have that if you have CBD on board. So we thought that maybe CBD is, protective in that sense. And that led us to the most recent study that we've now conducted, published. We have not yet published the results, so they're still pending. But I'm happy to share some preview results.
That would be amazing. So some hot off the press, or not even off the press yet, CBD trial
off
results.
The press yet.
What did you guys find?
Yeah. So back of the paper of Can We Make Cannabis, we argued that maybe you should tamper with the ratio of CBD to THC in cannabis, as a way of making it safer. And obviously, we know that specifically for the population where an individual has a psychotic illness and cannabis use disorder, there's very few methods that actually work in terms of trying to get them to quit or even reduce. So we needed to be a bit controversial and a bit innovative. So we thought that maybe if we devise a ratio of THC CBD which is less harmful to mental health, but still give them what they need in terms of THC and the effects of cannabis, then maybe we could make this vulnerable population less at risk. Because we know that patients with psychosis who use cannabis are at much greater risk of relapse and hospitalization, and the duration of hospitalization is longer and the general prognosis is worse. So it's a very vulnerable population that is in need of a new way of receiving treatment, basically. So this is one way in which we thought. So we did a study with 48 healthy volunteers, and each volunteer came for 4 separate experiments. On every experiment, they got the same amount of THC, which was 10 milligrams. We gave that as a vapor. So we vaporized cannabis. But alongside of this, 3 of the visits also contained CBD. So one visit, THC only. The other one would have a 1-to-1 CBD THC ratio, so 10 milligrams CBD, 10 milligrams THC. The other one, 20 milligrams CBD, 10 milligrams THC again. And then the last one was 3-to-1, which is 30 milligrams CBD, 10 milligrams THC. Now, this was all randomized, double blind. We couldn't tell, participants couldn't tell. It might not sound like a big study because it's 48 volunteers, but each volunteer came for 1 baseline visit where they had no drug, and then 4 drug visits. So all in all, with everyone who kind of dropped out of the study, it was around 300 study visits in total. So it took quite a while to do it. What we kind of saw was quite predictable and expected in terms of what effects THC had. So the THC effects were consistent with previous studies. THC, induced short-lived memory impairment during the intoxication compared to baseline. THC also induced psychotic-like symptoms as previously. But what's interesting and kind of counter to what we expected was that none of the CBD ratios actually conferred a benefit. So CBD, even 3-to-1, did not help with protecting memory performance or in terms of psychotic symptoms. And we had at least 3 different types of measures of psychotic symptoms, and CBD didn't help with any. We studied the pleasurable effects of cannabis. So each volunteer received a piece of chocolate at baseline and on every experimental visit, as well as got to listen to a song they really enjoy on every visit, because we know that normally cannabis increases, the pleasurability of eating, sweets and listening to music. And again, we found quite predictably that cannabis increased, the enjoyment of chocolates and music. But again, no CBD ratio were any different. So 3-1, 2-1, 3-1 was the same as THC only. We measured subjective effects, so asked people how high they got, how paranoid, how anxious they got, they felt relaxed, if they wanted food. All of these were extremely consistent, and whereby THC increased ratings of, euphoria, enhanced sound perception, enhanced color perception, feeling high and stoned, but CBD changed none of these. So they're very, very consistent findings. We, importantly as well, we collected blood samples from our participants before and 4 times after they had the cannabis. And that's quite important because, when you give someone cannabis, you can't always be sure that something else isn't happening within the blood of the participant. So maybe when you inhale cannabis with THC and CBD, maybe just the fact that the presence of CBD prevents THC from being absorbed. So that's something we'd call a pharmacodynamic effect. Now, we were able to rule this out because in the participants' blood, across all 4 ratios, we saw that the same amount of THC was absorbed. So there was no difference in THC blood levels in either of the 4 ratios. And when we looked at CBD levels, there was a beautiful dose response effect where 1-1 had more CBD than THC only, 2-1 had more than 1-1, and 3-1 had most of all. So CBD was well absorbed, THC was well absorbed. There was no kind of interference from CBD on THC levels, and we just didn't see any protective effects of CBD at all. So all in all, I think what we can say from these results is that at the ratios that we tried, so 1-1, 2-1, 3-1, and most cannabis that's available have much less than 3-1 CBD. At least the types of cannabis that are used for intoxication do not protect you when the level of THC is the same. And that's quite important because in real life, people go and buy cannabis. The cannabis plant is constrained in certain ways. So if you go for a 3-1 CBD ratio cannabis, the plant can only make so much THC and CBD because both compounds are made from the same precursor material in the plant. So if you want more CBD, the plant can't make as much THC. So high potency cannabis is the most available generally around the world. You can, the average amount in street cannabis in the UK is about 14-15%. And when you get a variety like that, you can't also have 45% CBD because the plant's not able to make that. So if you want a 3-1, that's going to bring the THC levels down in the plant. So by that effect, it does become safer. But what we tried was that the THC level stays the same and you just add CBD to it. And that's because we kind of wanted to maintain the same level of intoxication as high potency cannabis, but with less of the harms. When you do that, CBD does not protect. So the take-home message is that, unfortunately, you need to reduce the amount of THC that you consume, which is not going to be a popular, message, get less high, but it's the message that is the true one, at least so far, unless we maybe manipulate cannabis even further and go to crazy ratios like 10-1 or 20-1. But I don't think that that's going to be really feasible, because what we did see, and this is one of the few significant findings in our study, is that the more CBD you had in the ratio, the more the participants coughed. So CBD seems to be a bit abrasive to inhale. So going to 10-1 ratio or 20-1 would probably be quite unfeasible, because the participants or the users would be coughing quite significantly.
And how do you make sense of those findings showing that CBD doesn't seem to reduce the harms when inhaled in those ratios with your earlier study with the injected THC and the capsule CBD?
There are a couple of explanations, potentially. One is that was a chance finding. So, and there's a couple of reasons why that might be. So the sample size of the study wasn't as big as this present study. That one was 48 volunteers, but they each only came for one experiment. And that's important for a couple of reasons. So it brings the total number of experiments down, but also the same person is not receiving THC with or without CBD. So let's say we got a participant in the THC group. After THC, they got paranoid and psychotic, and their memory and performance got impaired. We'll never know for sure that that participant had been, if given a CBD capsule beforehand, would be protected or not. And that's kind of the strength of this more recent study, in that everyone was their own control subject in this study. So that could potentially explain it. So the design and the sample size could make the study a bit liable to what we call a type 1 error. So a false finding, really. The other is a more kind of pharmacological explanation, which is that 600 milligrams taken orally is slightly more than what we gave. If you think about it, it's closer to 12-1 ratio. However, there's also some breakdown of CBD when it's orally ingested. So something called first pass metabolism happens, whereby more of the CBD passes through the liver and breaks down to metabolites. Now, one of these metabolites, 7-hydroxy-CBD, has in some preclinical research been found to have pharmacological properties. Now, when you inhale CBD, very little passes through the liver, and there's very little first pass metabolism. So you would expect much more of 7-hydroxy-CBD to be produced when taken orally. Now, we can't know, because we didn't do those kinds of plasma analyses in that previous study, what the levels of 7-hydroxy-CBD was. We did it in this study. The levels were quite low, like very low, which you would expect with inhaled method. So it could be the fact that if CBD is taken orally, you get more of 7-hydroxy, and it's actually the 7-hydroxy-CBD that is protected. It's a hypothesis. It's not tested. We don't know if that's the case. And so I think it's the scenario in which it was a chance finding in the first study, and then the 7-hydroxy is the protective factor. Both of those explanations are potentially equally plausible. However, more recent studies have kind of shown the same pattern of finding, whereby CBD does not confer protection. So I think if I had to pick one of the two, I think the one where the previous study was a chance finding is the most likely.
I mean, that's really I love the thinking about it through the first pass metabolism way, because that's such a fun real world application of all the things that you learn in your pharmacology lectures. So I'm enjoying that. Gosh, okay. So where do you go from here with CBD? Does that is that it? Do you think in terms of it being a potential harm reduction tool for cannabis, or are you forging forward?
In terms of reducing the harms of recreational cannabis use, in terms of reducing acute paranoia and psychosis and memory impairment, it's looking very bleak for CBD. So I wouldn't keep my hopes up, really. In terms of reducing the harms of cannabis use from recreational users, I would think that a greater focus needs to be on THC potency, i.e., the dose delivered. So obviously, just because you use a higher potency type of cannabis doesn't mean that you need to use as much of it. So the amount that you put in a joint is the important thing, as well as the strength of that cannabis. So reduce the dose to an amount that does not make you, experience these things is probably the best advice. But that's, people don't use drugs that way, really. People often don't use alcohol in a moderate way. They use it to, go all out, party, and become fully intoxicated because that's enjoyable to them. And the same applies to all other drugs, including cannabis. So yeah, I think the main way forward with cannabis harm reduction lies in reducing potency and reducing the amount people use. How we achieve that, difficult question. Places where it's legalized, they have some tools which they could use, such as taxation by THC potency or by total dose in a package or a unit that they sell. Those things have been tried and tested and work when it comes to alcohol and tobacco in terms of reducing, the harms of the drug.
I guess one difficulty with cannabis still at the moment, and I think this is something you've spoken about as well, is the lack of the THC unit. So we don't. Well, maybe you'll correct me, but my understanding is we don't sort of have an agreed international, like we do with alcohol, of, this is what we will call as human beings a THC unit or a cannabis unit, and this amount of cannabis units would be the most safe, acceptable amount to use in a day or in a week.
Yeah, well, that's a really good point. That's a point that's been recently raised a couple of years back in the Journal of Addiction by a good friend and colleague of mine, Tom Freeman, and Valeria Lorenzetti. They argue that the standard THC unit should be 5 milligrams of THC, regardless if it's inhaled or taken as an edible, so taken orally. And they received, agreement from NIDA and Nora Volkov, write a response in which they kind of agreed with that standpoint. I mean, I wouldn't say that it's necessarily established now. I think more research is going to be done on this, and it's going to be useful from a research perspective to use this 5 milligram unit moving forward, and using that to quantify harms across different types of studies, both experimental and epidemiological. So yeah, I think we're slowly moving towards a better understanding of the harms of THC units. There's being more focus now on more careful recording of cannabis use in terms of not only frequency or cannabis use status, because if we go back a few decades, studies would just split people into two groups saying, have you ever used cannabis or not, which is not very helpful. I mean, it gives you very crude dividing lines, but you really need to go in depth. And we've got an article that we're submitting to Addiction Debates that might come out soon, where we're arguing a model of measuring cannabis where you collect very detailed information of the cannabis use history of the individual, and you ask which type of cannabis, ask them which strength, how much they use each time, and also try and incorporate biological samples such as urine, where you can more objectively quantify how much cannabis that individual is consuming. So when we have richer data in epidemiological studies, we can more closely link that to related harms. And that bodes quite well for the future of cannabis research in terms of, answering the question of causality. Because if we have a better understanding of the dose response effect, because one of the tenets of causality stipulates that there should be a dose response effect of the causal component to the harm, whereby, so if cannabis causes psychosis, someone who uses 10 times more should be at more risk than someone who uses much less. And equally, that kind of research will inform what levels may or may not be safe for people to use. So we do more studies with better measurements of cannabis use and strength of cannabis, then we might be in a situation in the future where we can say, we've got relatively, solid information now that if you stay within these recommended guidelines of use, or these units, similar to what we have for alcohol, although there's no safe level of alcohol consumption. But if you do stay within, I think in the UK it's 14 units of alcohol, then you're at reduced risk of harm. But when you exceed those recommended guidelines, the harms significantly go up. So hopefully in the future, we get to a stage where we could say the same thing for cannabis. Sadly, it's too early for that now.
And what about CBD? I know you mentioned that it's probably, potentially the studies so far say that there's not much in terms of psychotic and memory effects, but are there any other beneficial or any other potential effects of CBD that are interesting at the moment?
In terms of for recreational cannabis use and reducing harms, I would say not really. So, but CBD is very interesting still. So, it's proven to be an effective treatment for rare types of childhood epilepsies. And it's actually an approved medicine in the UK for this. So there's two conditions in which CBD is a medicine, and that's Lennox-Gastaut and Dravet syndrome. And there's still a lot of interest surrounding CBD and schizophrenia, so as a treatment for schizophrenia, not in combination with THC. So far, the evidence is somewhat mixed. There was a German study that found CBD to be as good as a regular antipsychotic. There was an American study that found no benefit of CBD. And there was a multi-center clinical trial where King's was the lead site, and I was involved in this study as well. This study found that CBD on top of participants' antipsychotics was significantly better in terms of reducing positive psychotic symptoms. So those are hallucinations, delusions. CBD improved that compared to placebo as an add-on. So the jury's still out. So we can't know for sure whether or not it works, or again, these small-scale studies have given us chance findings. But King's have now planned very large-scale clinical trials that aim to give CBD to hundreds of participants over extended periods of time. And I think within the next 5 years, we'll know whether or not CBD is useful for psychotic illness or not. So, that's a point of interest. And also, it could be an interest for cannabis addiction. So there's one clinical trial that's been published, and what they did is that they gave either placebo, 400 milligrams and 800 milligrams of CBD to people who have cannabis addiction, in which they also received kind of psychological treatment alongside placebo CBD. And the study found that both the 400 and the 800 milligram, the 400 was actually the best one in this study, was able to reduce the amount of cannabis that these participants used. And that was also confirmed objectively in the urine that was collected from the participants. And that's really promising, because so far there's no pharmacological treatments for cannabis addiction that have shown to be effective. So this is potentially the one candidate to kind of keep an eye on. And we know from extensive amounts of studies that CBD is relatively safe, because it's got very few side effects. The only one, we did a meta-analysis of clinical trials, and we found that the only one that was really significant was diarrhea. But when you included studies of pediatric epilepsy, so these clinical trials that made CBD a approved medicine, obviously that population have, serious physical illnesses, and they're on multiple medications. So you'll get many more side effects in that kind of population. So CBD is relatively safe. It's not completely safe. We know that CBD has an effect on liver enzymes. So CBD can block these enzymes' ability to break down other medications. So if you're taking medication for various psychiatric or physical conditions, taking CBD alongside that might prevent those medications from breaking down, leading you to have higher levels of that medication in your system, and thereby getting side effects from that. So there are, still some points of concern when it comes to CBD. It's not fully safe, but it's relatively safe when compared to other medications that are commonly used.
And I guess those points bring us on to the potential concerns with all the high street CBD. I think some of the furore and hype has probably died down since it all happened a couple of years ago. But what are your thoughts about the state of the high street and CBD?
Well, I mean, as you said, it's, the interests over the last few years. I'm not sure. I've not followed it recently to know if it's died down or not, but it just exploded. CBD was selling more than all of the other health supplements combined. So it became extremely popular, I think partly because it was seen as the good side of cannabis. So the harmless components of cannabis that had all the medicinal properties, but none of the negative properties. Extremely overhyped, and what tended to happen is that, within research, there's lots of kind of basic science studies that are done, so studies on cells and on animals. And as soon as a study like that was performed and showed positive results, these kinds of companies and online forums and Facebook groups all just took that as that means CBD is good in humans for all of those conditions. And that's sadly not how science works, because more often than not, when you find positive effects in animals or cells and you then scale it up to human studies, you often see that those compounds don't outperform placebo. And that's generally also been the case for CBD for a lot of conditions. Another big concern is obviously the dose of CBD. So some of these bottles normally contain 600 to 1,000 milligrams in a bottle. Can be sold for, I don't know how much now, 50 to 100 pounds per bottle, depending on the strength. And when compared to scientific studies where CBD is given as a medicine, the doses used in studies dwarf those that you can get in these over-the-counter products. So we would, in the schizophrenia study at King's, we gave 1,000 milligrams every day to participants. And that's not feasible for a normal person to buy 1,000 milligrams worth of CBD every day. So people would be using tiny homeopathic amounts of CBD that pharmacologically, just most of it will be broken down in the digestive system. So hardly any CBD would actually reach the bloodstream and have a biological effect on the person. So the doses are extremely low and unlikely to do any good. So what we would really expect is that, you know, people get placebo responses from over-the-counter CBD, which are common. You know, the placebo response is sometimes as high as 30 to 40% in some clinical trials. And big investments of drug companies into new drugs find that placebo just shoots them out the water. So they have to give up on compounds because they're no better than placebo. Another major concern is obviously that the over-the-counter products don't really live up to what's, you know, what's on the label. So there's been analyses of over-the-counter CBD across Europe and America. More often than not, there's big inconsistencies. So most CBD products are mislabeled, meaning that they either have more CBD than they say on the bottle, or they have less, and sometimes they have none at all. And also, more often than not, they have other contaminants. So a Czech study found that a lot of CBD oils had high levels of carcinogenic compounds because of inappropriate heating of the oils. And in America, they found CBD products, vapes, and oils that contain synthetic cannabinoids, so spice compounds, which are extremely potent. And there was actually a case of a small child with epilepsy who was given one of these CBD products that contained spice, and he sadly had to be hospitalized, subsequently recovered though. And the most common contaminant is THC, in fact, because these products are made from hemp, which is legal within the EU, and different countries have different regulations on the maximum amount of THC allowed in these cannabis varieties, because that's what hemp is. Normally it's 0.2% THC, but when you have a bottle of concentrated hemp oil of 0.2% THC, the most common sized bottles of 10 milliliters, that results in a bottle containing about 20 milligrams of THC. Now, 20 milligrams of THC is quite a lot. If you take the whole bottle, which I hope no one does, for someone who's not used to cannabis, that's going to be extremely strong. They might have a very unpleasant reaction from that. But for someone who takes these products on a daily basis, because the fat solubility of THC and CBD, THC in particular in this instance, might lead to, over the time, deposits being stored in fatty tissues, leading to a potential positive urine test for THC, although the person's never used cannabis. But because they've been exposed to low levels of THC over an extended period of time, they might test positive for cannabis. And that might have, legal or occupational repercussions for the person.
So don't use CBD off the high street sounds like the message there, probably. Or be careful.
I mean, I'm not going to say one way or the other. There's just no evidence that any of those products work. None of these companies have ever done a placebo-controlled trial to show that their products have a benefit for any health conditions. They only tend to produce, testimonials where the people who had a benefit get to say how amazing it was. There's not really evidence-based or unbiased in any sense. And also there's no way of knowing what's in the bottle. So save your money is what I would say.
As a cannabinoid researcher, are there any other components of cannabis or other cannabinoids that you're excited about or that you're interested in researching more?
It's a very good question. I think there's not yet from cannabis itself, but one cannabinoid that is, well, technically a cannabinoid is called rimonabant, which I find quite interesting. It's got a quite interesting story. So, cannabis obviously induces increased appetite. So a couple of decades ago, researchers thought that maybe if we produce compounds that are kind of the opposite to THC, we might be able to inhibit appetite and make people lose weight. So rimonabant is what we call an inverse agonist. So it binds to the same receptor as THC does, but it reduces the activity, as opposed to THC would increase the activity of the receptor. Big clinical trials were done. They had positive results. So people lost on average 5 kilograms over the course of a year on rimonabant. However, when it subsequently was licensed, they found that rimonabant doubled the risk of suicidality, anxiety, and depression. So the regulators pulled rimonabant off the market. It's been very little researched since. Now, why am I interested in a cannabinoid that blocks the cannabinoid receptor and has been linked to negative side effects such as suicidality and anxiety and depression? It's because of the potential of pharmacologically negating a cannabinoid intoxication. So far, we now have these synthetic cannabinoids being sold recreationally. They are much, much stronger than THC. And a lot of people are still showing up to A&E departments with acute psychotic symptoms and strange mental states that sadly there's no treatment for still. Now, all of these compounds are strong CB1 receptor agonists, so they bind to the receptor and activate it fully. THC is a partial agonist, so it doesn't activate the receptor as strongly. So what you would normally do, in, let's say the case of a heroin overdose, you'd administer naloxone, which reverses that. So a compound that binds to the receptor and displaces, the opioid that's causing the overdose. And similarly, you would think that putting cannabinoid receptor antagonist or inverse agonists such as rimonabant someone who's experiencing a cannabis intoxication, there's a potential of a reversal of that intoxication. It's still hypothetical. There's only been animal research on it. No one's really explored whether or not you can reverse an over-intoxication of THC or cannabinoids with rimonabant. But for me, that's something that would be interesting, and that's kind of a gap in the literature still.
Fantastic. And is there a take home or a takeaway message about, I guess, a commonly held misconception that you hear people say to you that you think is useful to correct about cannabis?
A common misconception. There's this phenomenon called the entourage effect, and it was written up about a decade ago or so by a cannabinoid researcher saying that all of these other cannabinoids in the cannabis plant and other plant compounds known as terpenes and flavonoids are really important for the effects of cannabis. They're basically smell and flavor compounds generally. You can find terpenes in soaps and scented candles. So what he suggested was that these compounds are very important to the medicinal benefits of cannabis. Basically, THC on its own is not as good as THC with the other cannabinoids and the other terpenes. And this has just, been accepted as gospel within the cannabis using community, as well as, the cannabis industry. Probably because it's a really profitable, notion of these exciting little compounds that help you and change the effects of cannabis. There's no research behind it whatsoever. The little research that has been done on the interaction of cannabinoids and terpenes have been negative. So there's no evidence that they benefit in any way. So in terms of one big misconception, that is the one of the entourage hypothesis, which is that, adding the flavonoids will make cannabis more medicinal or safer to use. There's no evidence for this.
Amazing. Amir, thank you so much for sharing your time and sharing all that knowledge and research experience with us. It's been fascinating to listen to, and I hope that everyone will take lots away as well.
You are listening to the Thinking Mind podcast. Thank you so much for listening to this episode. If you enjoyed it, please share it with a friend or give us a rating. It really does help people to find us. If you find the podcast valuable, why not buy us a coffee to help keep us going? There's a link in the show notes. As ever, we love to hear from you and love to hear what you think. So drop us an email or get in touch on social media. Thank you so much.